Hello, everyone. I'm very honored to be presenting my team's work here today at the SBI. I will be discussing our project regarding persistent disparities in women lost to follow-up after a BI-RADS 0 assessment despite enhanced institutional interventions. Our only disclosure is that one of the authors, Dr. Susan Harvey, is the Vice President of Global Medical Affairs of the Breast and Musculoskeletal Divisions at Hologic. As mandated by the MQSA, the current standard of care for reporting a detected abnormality on screening mammography to a patient is only through written communication in the form of a recall lay letter. This is required to be mailed to the patient within 30 days of the assessment. Although no official recommendation exists through the MQSA, CDC guidelines recommend that a woman should return for a diagnostic follow-up examination within 60 days of a BI-RADS 0 assessment. At our institution, however, we are slightly more flexible and use 90 days as the cutoff instead of 60 days. Previous studies have demonstrated that abnormal results are better understood by patients when notified in person or by telephone compared to in writing. Because of this, in 2013, our institution began calling each patient the following business day after a BI-RADS 0 assessment in an attempt to schedule their follow-up examination. In 2017, we updated this to a standardized telephone script protocol and implemented the protocol across all 4 of our outpatient breast imaging sites. In an attempt to further improve patient care, in 2019, we revised our recall lay letter statement to a 6th grade reading level for further patient inclusivity. Our data demonstrates that patient adherence to a diagnostic follow-up examination significantly improved after initially implementing the telephone communication protocol in 2013 compared to just written communication alone. However, there was still a percentage of patients who were still not returning for their diagnostic follow-up examination in 2018 and 2019 despite our aforementioned interventions. Thus, our study was conducted to investigate what socio-demographic factors were associated with this specific patient population who were lost to follow-up. To address this, we reviewed all data from screening mammograms with a BI-RADS 0 assessment, excluding technical recalls, between February 15, 2018 and June 15, 2019. This period was chosen as it was after we had implemented both the telephone intervention protocols and revision of our recall lay letter language. For this study, we defined patients lost to follow-up as not returning for a diagnostic workup within 90 days of a BI-RADS 0 assessment, as this was our institutional standard for lost to follow-up. The chi-square test was used to compare patient adherence between patient sociodemographic factors. The Kruskal-Wallis test was used to compare patient median days to follow-up and respective interquartile ranges between the same patient sociodemographic factors. During our study period, we had a total of 3,871 patients with a BI-RADS 0 assessment excluding technical recalls, of which 267 patients, or 7%, did not return for a diagnostic follow-up examination within 90 days. The mean age of women who followed up was 56.3, and those who were lost to follow-up was 56.2. Thus, age was not determined to be a statistically significant sociodemographic factor. When separated by race, African American patients had the highest proportion of women who were lost to follow-up, which was statistically significant. This almost doubled the proportion of white patients. Next, we evaluated our data stratified by imaging site. Our data was derived from 4 outpatient breast imaging centers associated with our institution. Because we know that each imaging site services different patient populations, we wanted to investigate if this affected patient adherence. We broke down each site by 3 socioeconomic factors: individuals below poverty level, median household income, and percent of high school graduate or higher. The data was obtained from the 2013 to 2017 United States Census Bureau. This table shows that the patient populations of sites 3 and 4 have higher levels of individuals below the poverty level and have lower median household income and percentage of at least high school graduates compared to sites 1 and 2. Therefore, not surprisingly, sites 3 and 4 had higher proportions of patients who were lost to follow-up at 90 days compared to sites 1 and 2. This was also statistically significant. When controlling for the breast imaging site, we found that race was an independent predictor of lower likelihood of follow-up. Specifically, regardless of imaging site, African American women were about 1.8 times less likely to follow up within 90 days compared to white women. When controlling for race, we also found that certain imaging sites were independent predictors of lower likelihood of follow-up as well. Specifically, regardless of the patient's race, patients from sites 3 and 4 were also about 1.8 times less likely to follow up within 90 days compared to site 1. Of the women who actually followed up within 90 days, African American women took longer to attend their diagnostic follow-up examination compared to white women. Although this is only a small difference of about 4 days, it is interesting that there is still a racial disparity in the timeliness to a diagnostic follow-up examination between the races. Previous studies have demonstrated that breast cancer in African American women tends to have a more aggressive course and results in higher mortality rates for these patient populations. Lack of timely follow-up, which results in delay in diagnosis, may be an influencing factor in this. Furthermore, women who live in poorer counties in the United States have been found to have a lower 5-year breast cancer survival prognosis, which may be attributed to lack of adequate access to health care. Therefore, the ability to promote timely and consistent follow-up may result in a positive outcome for these women. In summary, our results illustrate that persistent racial and financial disparities exist among women who are lost to follow-up despite interventions that go beyond the standard of care mandated by the MQSA. Our study emphasizes a need for more frequent and targeted interventions to reduce the number of women lost to follow-up and potentially help close these disparity gaps. By doing so, we are optimistic that this can potentially improve the quality of individualized breast cancer screening for these women. I would like to take a moment to thank all the authors for their hard work on this project. We would also like to thank Jen Zuck and Boris Feldman for their assistance with data acquisition from our EMR. Thank you so much for your attention.